So I invite Dr. Lakshmi. She's currently consultant at Malabar Medical College. She's professor at Malabar Medical College and consultant at Abbott Hospital, Calicut. And she's going to talk about an approach to patent strabismus causing AHP. If there are any questions, we can take it at the end or in between. Please feel free to ask questions.
Okay, thank you, Dr. Neena. And I'll be dealing on head posture caused due to patent strabismus. So before going to what is the head posture, just a briefing on patent strabismus. So what is patent strabismus? It's a vertically concomitant horizontal strabismus and a substantial difference between down gaze and up gaze. So what is the substantial? 15 prism for a V pattern, 15 prism of difference between the horizontal deviation in up gaze and down gaze for a V pattern, and 10 prism for A pattern. And the measurement is done at 25 degrees up gaze and 35 degrees down gaze by tilting the head in the chin up and chin down posture. It's seen in 12 to 50% cases of horizontal strabismus. We do see occasionally Y pattern and lambda pattern, but it's not very common, so we'll stick to A and V patterns for now. And if we see this child in the first photograph, he has a V pattern esotropia, and you can see the ESO is increasing in down gaze. The picture on the right shows a V pattern exotropia where the divergence is more in up gaze. So the next patient is an A pattern exotropia. In this you can see that the eyes are diverging while looking down. The other thing that I need you to note in these are the 9 positions of gaze. So if you see these up gaze pictures, we can see that there is an inferior oblique overaction or an over elevation in adduction seen in this patient and in this patient, both these patients. And in the next picture, if we see, there will be an over depression on adduction, that is a superior oblique overaction in down gazes. So far said, we come to the first step of measurement of pattern. So the patent strabismus head posture is important in 2 aspects. One is a patent strabismus can cause a head posture, and the second thing is when we are measuring a patent strabismus, if we don't correct the head posture and the patient is keeping a head posture, our measurements might go wrong. So measurement of pattern is of utmost importance. We need to measure the patient in 9 positions of gaze and find out which muscle is overacting to find out oblique overactions. Keep in mind pseudo patterns where we get V pattern, which is not actually a V pattern, it's due to an uncorrected accommodative esotropia, and a pseudo V pattern exotropia in intermittent exotropes who fuse in down gaze. So coming to the head posture, the classically described head postures in V and A patterns are chin up and chin down, and typically it is mentioned for people who fuse in these head postures. So a V pattern exo and an A pattern exo will fuse in chin up, and A exo and V ESO will fuse in a chin down posture. But when we assess the head posture, we need to see whether the patient is actually keeping a chin up or chin down, or is there something else along with the patent strabismus. So this is the V pattern ESO boy. On close follow-up, he has a right head tilt and a left head tilt. So he had an dissociated vertical deviation along with the patent strabismus. So that was giving rise to the tilt most probably. And he was alternately suppressing his eyes. So this is the patient with an A pattern exotropia, and in these pictures we can see that the patient is keeping a chin down posture, but along with it she has a small right head tilt, and in this position the exotropia is actually more, and she also had a DVD. This was a patient with Helveston syndrome, A pattern exotropia and DVD. And as already mentioned, craniofacial abnormalities we need to see for plagiocephaly. We can have a V pattern, but it's not actually due to an oblique muscle overaction. So the next thing we need to check is, why are we bothered about this? Because as seen in the other pictures, it could be to facilitate fusion, it could be to separate the images as far as possible, it could be due to an associated DVD, or in the plagiocephaly case that I showed, she didn't have an abnormal head posture because she had amblyopia in one eye. And it could be a combination. This will influence the management. So we need to know a little bit about why patent strabismus is caused. As seen above, the overacting muscles or the orbital anomalies could be a cause, or it could be due to loss of fusion. So loss of fusion is told to produce a torsion which can cause an abnormal pattern. But this theory doesn't hold good because there are patients in which you see pattern strabismus and overactions, but we don't see a torsion. So we need to assess the torsion in these patients. And almost all cases of oblique overactions, if we see a torsion, it is definitely an oblique overaction and it is not some other thing. And the next step would be to assess the level of binocularity. Most of the congenital strabismus patients with patterns have a subnormal binocularity, but acquired cases or late onset cases can have a good binocularity. So if we are tackling the obliques, that can result in a torsional diplopia. So how do we manage? If the obliques are not involved, we upshift or downshift the horizontal recti and medial rectus towards the apex and lateral rectus towards the base of the pattern. And in oblique overactions, we should tackle the obliques necessarily. And suppose the inferior oblique is overacting, if there is a dissociated vertical deviation, it needs to be corrected along with it. So we might need to do an anteriorization procedure along with the recession of the inferior oblique. So these are the pre and post of the other two patients that I showed before, the V pattern ESO. He underwent bimedial recession with inferior oblique anterization because he was having a dissociated vertical deviation. He was pretty much okay. The pattern has almost collapsed. And head posture, I'm yet to assess because it was just the third day post-op. And the second patient with Helveston syndrome, her preoperative head posture and head tilt actually subsided to a large extent, but she was not having a good fusion. She does a lot of videos, so this is the post-op video and that doesn't show a significant head posture. She underwent a bilateral lateral rectus recession with a posterior tenectomy of superior oblique and an IR plication for the DVD. So her pattern also had collapsed. To sum up, pattern strabismus and abnormal head posture can appear complicated. We need a stepwise approach. We need to assess the binocularity, always assess the torsion, and don't hesitate to operate on the obliques if it is necessary, and no single approach might work in these cases. Thank you.
So, in Helveston syndrome is probably the worst strabismus you can get, I think. So there are some, thoughts on doing all the
obliques. Yeah.
So what is your experience? Have you touched on?
No, that was only one patient of Helveston I had seen. I had followed up her for I think 3 or 4 years. Because initially they were not willing for surgery. She had associated quadriplegia or something, cerebral palsy sort of problems. But her mentation was fine, and she didn't have significant, she didn't have binocularity. One eye she was suppressing one eye. So, and torsion was there, significant torsion was there. So I planned to go ahead with dealing with the obliques, superior oblique alone, than dealing with the inferior oblique, because I felt that was a little bit more conservative than going in for all the superior obliques, because I didn't want an abnormal result to the superior oblique. But inferior rectus plication for the DVD gave a good result.
But if at all we are doing, I think, staged, right?
Stage, two procedures.